like to thank you guys all for volunteering your time and effort as a part of the Kdsap Screening and Awareness Program. My name is Connie Ree, and I'm a nephrologist who's been volunteering in this program for the past few years. And it's an honor to be able to talk to you guys today about infection control and professionalism. So I have three main objectives in my talk. The first is to begin to impart to you skills that are essential to practicing medicine. This not only includes medical volunteer work, but it also includes your future medical school rotations, residency, and fellowship, and also basic science and clinical research settings. Number two, I'm going to discuss infection control, including standard precautions, universal precautions, and preventing needle, stick, and sharps injuries. And number three, I'd like to close with medical professionalism, also discussing patient privacy and dress code procedures when you're volunteering. So let's start off with standard procedures. What are they? Well, they're defined as infection control practices used to prevent transmission of microorganisms in the medical setting. They're intended to protect both patients and healthcare personnel, and they should be used for all patients all the time. There are two key components of this, which include hand hygiene and barrier precautions for body fluid exposures. Do standard precautions really make a difference? Well, history would tell us that they in fact do. In 1822, it was first discovered that lime chlorides could remove foul odor from human corpses, so these were essentially the first disinfectant. Later in 1846, a renowned Hungarian physician, Dr. Semmelweis, identified that there were higher infant mortality rates and sepsis among infants who were delivered by doctors and students coming from autopsy suites versus midwives, despite the doctors and students conducting hand washing. After introducing lime chloride disinfectants, they saw a significant decrease in these infant mortality rates and sepsis rates among doctors and students. So recent data would tell us that there is still a need for standard precautions. In a 2002 CD study almost 11 years ago, it was reported that 1.7 million healthcare-associated infections and 90,000 associated deaths occurred in U.S. hospitals. So I'd like to pause here and conduct a little quiz. So the first question is, previous studies have demonstrated that compliance with hand washing, including ICUs, is A, greater than 90%, B, more than 75%, C, less than 50%, D, less than 10%. So I'll pause here. And the correct answer is B, more than 75%. Pretty good, but still pretty far off from the mark. Number two, when should I wash my hands? A, immediately before touching a patient, performing a procedure, or manipulating an invasive device. B, immediately after touching a patient or contaminated items. C, before putting on gloves. D, after removing gloves. E, after leaving a patient's room, even if I didn't touch the patient. F, all of the above. So the correct answer is actually F, all of the above. Next question, which hand hygiene method is more effective in killing bacteria? Is it A, soap and water, or B, alcohol-based hand rub using foam or gel? It would be B, alcohol-based hand rub. However, one should keep in mind that if a patient has Clostridium difficile infection, alcohol-based rub cannot kill the spores, so soap and water is needed. Which hand hygiene method is more damaging to your skin? Is it A, soap and water, or B, alcohol-based hand rub? The correct answer is actually A, soap and water, believe it or not. And how long do you have to rub your hands together when using soap or water? Is it A, 5 seconds, B, 15 seconds, C, 1 minute, or D, greater than 2 minutes? I'm going to be a surgeon. The correct answer is B, 15 seconds, but if a patient has known vancomycin-resistant enterococci infection, 30 seconds is actually needed. And how long do you have to rub your hands together when using an alcohol-based rub? Is it A, 5 seconds, B, 15 seconds, C, 1 minute, or D, until your hands seem dry? The correct answer is D, until your hands seem dry. So this picture is intended to show you guys the 5 moments during which we need to consider hand hygiene. 1, before touching a patient. 2, before the clean aseptic procedure. 3, after a body fluid exposure risk. 4, after touching a patient. And 5, after touching a patient's surroundings. And I just want to emphasize that when one is washing their hands, it's really important to cover all the surfaces, including fingertips and fingernails, getting in between the fingers, and also focusing on the thumbs. I now have to talk to you guys about barrier precautions. Now, these are personal protective equipment that should be used if you anticipate exposure to blood, body fluids, excretions, secretions, mucous membranes, and non-intact skin. And these include mask and eye protection or face shield, gloves, and gowns. Now, it's important to emphasize that gloves are not 100% effective. and one should use caution when using non-hospital approved hand lotions because these can actually break down latex gloves and they could be contaminated. Furthermore, artificial nails, jewelry, ties, and stethoscopes can transfer organisms, so it's better actually not to use some of these items and to wash your stethoscopes after touching a patient, before touching a new patient. And I would advise keeping your natural nails shorter to less than 1/4 of an inch. And I'd like to talk to you guys about the next level of precautions, that is universal precautions. Now these include protection from bloodborne pathogens, which include hepatitis B, hepatitis C, and HIV. Now it's important to note that these are not only transmitted via blood, but through other body fluids as well. In discussing the risk of these bloodborne pathogens, hepatitis B actually has virtually no risk if you are vaccinated. However, if one is not vaccinated, the risk of transmission is 6 to 30% with a needle stick injury, which is 100 times that of HIV. Now, it's very interesting to note that with the introduction of vaccinations, the frequency of hepatitis B transmitted infections has significantly decreased from greater than 10,000 in 1983 to less than 400 in 2001. It's very important that one seeks treatment after an exposure immediately, because there's a narrow window during which one can get hepatitis B immunoglobulin and vaccination to try to risk the likelihood of transmission exposure. Now, in terms of hepatitis C, the risk of transmission is actually 2% with needle stick injury, and there's unfortunately no treatment following exposure. In terms of HIV, there are variable risks of transmission depending on the route of exposure, with the highest risk of needle stick injuries. And drug therapy for this has to be administered virtually within hours because it may be less effective after 1 to 1.5 days. And there are a number of side effects that can be associated with this medication, which include GI side effects, hepatitis, low blood counts, kidney stones, fatigue, and headache. So I think the bottom line is we really have to take all the measures that we can to try to avoid risk of exposure to bloodborne pathogens. Now, there are a number of potential opportunities to get a needle stick injury. You guys are going to be doing finger sticks with blood glucose monitoring, and so it's really important to consider all these things. What I thought was interesting is that among all reported causes of needle stick injury, 42% actually occurred after the procedure. So it's really important to retain your attention on the procedure, not only before and during the procedure, but also afterwards during the cleanup. In terms of other general tips, do not recap your needles, immediately dispose of used needles in sharps containers, use caution when transferring fluid between containers, use medical devices with appropriate safety features to prevent injury, and always use very precautions. My personal procedure tips include thinking out the procedure beforehand. Set up everything beforehand because setup is 75% of the procedure. Keep a sharps container close by. Keep your field clean and organized. Do not rush. Get help even if you think you don't need it. Maintain your concentration to the end. And when throwing your sharps away, keep your bare precautions on. Dispose of things by yourself. And if you're not sure if it's a sharp, put it in the sharps container. If you've been exposed, what do? Well, immediately wash your needle stick and cut injuries with soap and water. Flush splashes to the nose, mouth, and skin with water. Irrigate your eyes with clean water, saline or sterile irrigants. And report your exposure to occupational health or infection control immediately, because you may need immediate post-exposure treatment as well as serial blood tests. I'd like to finish with a discussion on medical professionalism. And I have 3 question marks here because this is something very difficult to define and articulate. But when we think about medical professionalism, I think that there are images that come up in our head. And I've actually drawn upon some famous medical characters on television to help us try to think about what medical professionalism may be and what it is not. So this includes Denny and Izzy, our beloved characters on Grey's Anatomy. Although we like them very much and we agree that Izzy is a very caring doctor, I think we would all agree that it is not really appropriate, not considered medical professionalism, to have a personal relationship with one's patient. Now, I think we all know Dr. House from the famous TV series House. He's an excellent diagnostician, but he's a little bit rough and sometimes temperamental with his patients and colleagues and students. So I think we would all agree in that context, it probably is not medical professionalism. And lastly, I think we all enjoy watching Dr. Cox and Dr. Hart's rapport on the TV show Scrubs, but I think we would all definitely agree that strangling one's supervisor is not considered medical professionalism. So what is medical professionalism then? Well, a task force on professionalism from David Geffen School of Medicine at UCLA actually sought to define this more clearly for us. It's being committed to carrying out one's responsibilities. It's being adherent to ethical principles, and it's being sensitive to diverse patient populations. Why is this important? Well, professionalism is the most important predictor of having disciplinary action in one's later career, more so than grades, test scores, and demographics. It is very important for patient satisfaction, and most importantly, it's important for building your patient's trust and confidence in you. This will increase their compliance and follow-up in the future. And lastly, it's been shown to avoid complaints and legal action. There are 9 key responsibilities in medical professionalism, which include a commitment to competence, honesty, patient confidentiality, appropriate relationships with patients, improving access to care, improving quality of care, a just distribution of finite resources, a commitment to scientific knowledge, maintaining trust by managing conflicts of interest appropriately, and a commitment to professional responsibilities. There are also 6 key behaviors, which include number 1, altruism, putting your patient's interests above your own. Number 2, accountability. Number 3, excellence, going above and beyond for your patients. Number 4, duty, free acceptance of commitment to service. 5, respect to others, not just medical doctors, but especially patients, students, nurses, and other staff that are part of your medical team. Number 6, honor and integrity. I can't emphasize these things enough. What I consider to also be a part of our duty in medical professionalism is enforcing the Health Insurance Portability and Accountability Act. This is an act that was designed to protect the privacy and security of patients' health information. And what information should be protected? This includes any info about physical or mental health of your patient, spoken, written, or electronically stored information, which includes the patient's name, medical record numbers, date of birth, videos, photos, and x-rays of their medical treatment and care. We should always practice the minimum necessary standard. Providers and others should only access the minimum amount of information necessary to get the job done. And consequences of not following HIPAA include severe disciplinary action, which include loss of employment, fines, and even imprisonment. I'm going to go over a couple of scenarios and ask you if these might be appropriate or inappropriate. So talking about patients and using their names in a public place. So this is inappropriate. We should not talk about our patients outside of the context in which we're taking care of them and trying to further their care, and we should not use their names particularly loudly in any setting in which it does not serve this purpose. Declining to give an update on a patient's medical status to a family member. This would be considered appropriate. If a patient is competent, we cannot give any information to others about their medical status without their permission. Disposing of patient's medical charts in the trash. This is inappropriate because this could contain protected health information that has to be disposed of in an appropriate receptacle that ensures the patient's privacy. And in the hospital, we have a lot of designated receptacles in which we can dispose of this information. Looking at family members' electronic medical information. This is not appropriate. Again, if a patient is competent, they have to give permission for their information to be accessed, such as a waiver of release. And finally, misplacing a flash drive that has a patient's medical record number on it. This is absolutely not appropriate. In fact, I would advise that you not put any patient information on a flash drive because of the potential risk of losing it. In terms of some final HIPAA do's and don'ts, treat all patient data as if you were the patient, including spoken, written, electronic information. Shred or properly dispose of all patient information. Use encrypted and password-protected electronic devices, and do not share your passwords. Use secure networks for emails with patient info, and do not talk about patients in public places. Always use this discreet voice when you're discussing their care, and practice the minimum necessary standard. I think it's also important to talk about dress code as a part of your volunteer efforts. So I have a couple cartoons here. Number 1, Johnson. I think you misunderstood our casual Fridays dress code. And number 2, I was going to be a stockbroker, but they make you wear a belt. As you guys go forth into the community and volunteer and help serve various patient populations, the goal is to look like a medical professional. It's important that you look neat and clean, which will increase your patient's trust and confidence in you. You should avoid tight, sheer, or revealing clothing. You should wear a badge and white clothing or another uniform that identifies who you are and that you're a part of Kdsap. Do not wear jeans or shorts. Do not wear tank tops. Your top should cover the abdomen, back, and chest. Avoid artificial nails and fragrances. Wear closed-toed shoes to protect yourself from body fluid exposures. And do not wear caps, hats, or bandanas. Now, more specifically, how can I incorporate all this information of professionalism into my actual volunteer work? So I have some tips for you. Number one, demonstrate accountability. Be on time. Do your part to help out. Make sure that your testing area is clean. Make sure that you are clean. Smile and introduce yourself to the patients when you meet them. Explain to your patients what you're going to do to them before actually laying hands on them or examining them, because it may take them by surprise. Make sure that your patient is comfortable throughout the interview and exam. Check in with them frequently. Make sure that your patient's privacy and modesty is maintained throughout the interview and exam. Listen to your patients and thank your patients after the interview and exam. And finally, I'd like to close with some famous quotes by the doctor who is considered the father of medicine, that is Dr. William Osler. He's actually the first physician that really encouraged that we bring students into the medical setting to talk and interact with patients to increase their medical knowledge and exposure and experience. So the first is, the practice of medicine will be very much as you make it. To one, a worry, a care, a perpetual annoyance. To another, a daily job and a life of as much happiness and usefulness as can well fall to a lot of man, because it is a life of self-sacrifice and countless opportunities to comfort and help the weak-hearted and to raise up those that fall. Number two, we are here to add what we can to, not to get what we can from life. And number three, care more for the individual patient than for the special features of the disease. Put yourself in his place. The kindly word, the cheerful greeting, the sympathetic look, these the patient understands. And I thank you guys all for your time and efforts in volunteering. These things are so important. They will help so many patients. I think also help you as well. Thank you.